If I could get your attention, we're going to go ahead and get started. We're going to call the roll. Lori Boyette. Here. Scott Christopher.
Here.
Brian Eastridge.
Here.
Dr. Gandhi.
Here.
Carla Helsek.
Here.
Elmo Lopez. Lisa Price.
Here.
Alex Ramos.
Here.
Christy Reeves.
Here.
Kathy Rogers. Lori Vinson.
Here.
And Robert Winchell. So Kathy and Dr. Winchell both explained that they would not be here today. So I believe we do have a quorum. We can move forward, right? You have a quorum. So we're going to move forward. Colin. So is he have an update from the state?
We have none, yeah.
Nothing? Any state legislative activities from the state that we need to know about? This is more pertaining to Sunset. Any updates?
No. Not that I know of.
This may be a fast meeting. Next item on the agenda is the trauma system plan. Dr. Eastridge.
Do we want to go through the slide story? The plan itself?
Okay. Do you want to just do the committee and then come back to the slides, or?
Yeah.
Okay. The registry stakeholders group, is Mr. Drucker in the room? Can you please step up to the microphone?
I guess I'm to give an update on the registry work group. Well, we met at noon today, and we talked a little bit about where the registry is. We talked about where we are with NEMSIS. We talked about where we are with the whole notion of mandatory elements, required elements, recommended elements, optional elements, and how moving to the national standards for both NTDB and NEMSIS would alleviate a lot of that. Those questions and concerns. We also talked about the availability of a friendly user guide. Our stakeholders requested a friendly user guide to show them the ins and outs of the Maven registry. This user guide is now available on our website, dshs.state.tx.us/injury. It's 185 pages long, and it's screenshots, and my staff did a really good job. Majority of the calls that we get coming into my office can be answered by this user guide. So thank my staff, and thank some of the other stakeholders for their input and getting this moving forward.
Any questions for Chris? You're going to see some additional data that came from Chris and his team. And so I personally just want to say thank you to Chris and his group, because they've worked really hard to bring data forward that we can actually begin to try to make some decisions on from the entire region. So thank you, Chris. Trauma Medical Directors Work Group, Dr. Eastridge.
So, same thing you have.
You notice nobody's sitting by me, right?
Strategic. So the Trauma Medical Directors, we've had some electronic communications. A lot of our effort has gone in this quarter to developing the strategic plan for the system. But salient to that effort, and in some of the specific objectives and aims of that strategic plan was developing education, developing evidence-based practice guidelines, and to minimize practice variation. And so we came up with a couple of ideas to start to develop clinical practice guidelines. Probably we'll start right along the lines of the Trauma Quality Improvement Program, the TQIP program, because they've actually already put out one on basically shock and resuscitation, which is a low-hanging fruit and very important to the trauma system. Geriatrics, and then talking to Alex and a couple of other folks, probably also brain injury shortly to follow, or early management of brain injury in the pre-level 1 arena. And that's all we have right now. We'll actually have substance for our meeting in August.
Good, thank you. So at the November meeting, we had a session where the RACs actually gave an update, so we decided that we would continue that. So we divided the RACs up. And so today we're going to hear updates from RAC A, B, C, D, E, F, G, and H. So anybody here from RAC A wants to give an update? And this is just a quick little overview of how you're doing, what your issues are. Anybody from A?
He's supposed to be coming. I'm not aware.
Well, can we come back?
Skip over and come back.
We'll come back. RAC B?
Have to bring my notes. Good afternoon.
Good afternoon.
I had sort of forgotten what all we were going to talk about, but I've got a few things that we'll do here. Kind of what we wanted to report to you we've got going is some of the things we consider successes within the RAC, of course, are with our Performance Improvement Patient Safety Group. Takes on quite a bit of duty there, doing regional review of cases where everybody from the region can bring something in. We review that, follow it start to finish, and try to provide an educational opportunity out of a lot of those. Months where we don't have the run reviews, what we do go ahead with educational opportunities, which one of the things coming this month is our ABCs of trauma care. Also within the injury prevention group, having a regional EMS patient care report has enabled us to form a regional data bank where we've been able to pull information for such as car crashes, falls, and such as that, so we can start working on some educational opportunities throughout the region. We also have presented Shattered Dreams programs. We have a regular ongoing car safety seat program that travels through the region where we're able to do safety seat checks and also provide safety seats for those that might not be able to afford those. Bicycle safety programs also ongoing, and we've also purchased helmets that we're able to give out at those events. For HPP, the regular activities ongoing on that. Each week, of course, is the have bed reports. They do that. We do monthly communications drills throughout the region as well for both hospitals and EMS, and so that we can see what the response is on that. Do education for bringing systems on that are having some problems with those things and such as that. So some of the things, and those were all of our positive things. Some things that we kind of threw in as being stressors for us, I think, are things that are shared with a lot of places throughout the state. One is simply a loss of personnel. And we're not talking about within our RAC organization, we're talking about in the systems throughout the whole region. EMS is impacted heavily, and through some of the other committee meetings that we've heard today, that is a huge concern from an education standpoint, a recruitment and retention standpoint. We have places, particularly out in our part of the country, in the rural areas, where our EMS providers are aging, and we're not getting the recruitment from the younger population that we would like to have. So that is a bit of a stressor for us. We're still, just like everybody else, trying to work through that, figure a way to bring people into the profession to continue to provide care. We have lost a lot of people in the last couple of years simply because of the oil industry. People leave by the droves from both, mostly EMS profession, some out of the nursing profession that have moved into the oil field because of the money they can make. As long as that's there, I think we'll continue to suffer that problem. We see a definite loss of interest from our younger population. It's hard to get them to move in, to put the kind of time in to enter the profession for the return. And I think that's something that we have to address. We work really hard trying to figure a way through that, and we watch everybody else the same. Hopefully we can play off each other. We're seeing a decrease in the level of services we're able to offer. I know in my particular instance, where I'm the director, from the time I went to work in the 80s, up until just in the last few years, we always offered a 2 paramedic truck. And we've taken that to a paramedic EMT. And, you know, and if we don't see a change in the future, we may be looking at EMT trucks with paramedic second out, you know, responses. We don't really know what's going to happen there, but we see that throughout the region. We've even had a few services that we've lost, so that's a pretty good stressor for us where we're at there. Those are just some of the notes I threw together. If you have anything in particular you'd like to ask, I'll see if I can answer.
Do you have any specific issues that this committee can address for you?
You know, I think that, you know, I've heard the discussions as we've gone since I've been attending the meetings. I don't know anything in particular that we can ask for other than support and gathering of ideas on how we can address these type of issues.
Thank you.
Okay.
Thank you very much. RAC C? Anybody here from RAC C? Did RAC A come back? Tag, you're in, huh?
Tag, I'm in. So we look at educational opportunities in what we've done in the last couple of years. We've partnered with TTAF and started having conferences. We started out with 1 conference last year, and this year we're hosting 3 conferences, 2 with TTAF, 1 with the MSC, Stroke, STEMI, a pediatric conference, and we'll have a Burn and Blast conference that was kind of modeled after what happened or what they did in the Midland region. We still allocate funds as we can for educational opportunities through that. We're working our PR process, our SPI process. We're trying to get into a situation where we can, by collection of data quarterly, we can help that data collection drive the thoughts and the mission behind what our SPI committee can look at and help navigate through. So that gets us to there. We're pretty fortunate. All of our acute care facilities participate actively in the RAC. So we have 100% turnout and participation with them. Most of our agencies, EMS-wise, participate. It's running about 92, 93%, I think, off the top of my head. Now, what we have seen in struggling, and we talk about where our shortfalls, interfacility transports, getting patients to the interfacility transport, sorry. In getting those patients moved, we have staffing problems. Our ERs have the 2-hour windows, and looking at those, we run into some complications there. It's a current struggle. Like we've talked about in some of the committees throughout the day, we try to track EPCRs left, or PCRs left at the facilities, and trying to find that happy medium. We have agencies closing. When we talk about EMS providers, we've lost about 17% of our EMS agencies in our RAC. And it's not because somebody else is opening a new one. They're closing the doors and trying to find out what's causing the closure. Naturally, it's funding and manpower when you talk about education. There was a little bit of concern. We have a lot of critical access hospitals in our area, and when they started looking at the critical access hospitals and removing the waivers, or removing that critical access designation because of the waiver exemptions, Torch got involved, and we had really had a string of hospitals, 4 or 5 in our area, that were concerned about if that goes away, what will they do? So far, we've visited with Torch and a few others, and we're working as we can. That's about it. Where can you guys offer some help? Education always is a struggle, you know, with TTAF being able, they come up and help. Outside of that, we sit, we listen, we try to participate actively here and gain ideas through sharing of information and such like that. So not really anything specific right now.
Thank you very much. RAC C? RAC D? Anybody from RAC D?
Hey, I've taken the liberty of providing each of you a copy of our most recent annual report. Somebody was just giving me an elbow, so you didn't do this just for this meeting, did you? No, I didn't. We actually do these every year, and so it's an overview of our last programmatic year, which is about the last 18 months. There are additional copies outside in case other folks might want them. But what I would like to do is introduce Ms. Winga Manning, who is one of our staff members, Emergency Healthcare Systems Coordinator, and she's going to do a little update on some of the more recent activities she's been involved in. When you're ready.
Thank you. Just gonna pull up my. Wrong. So I'm just gonna go over a few. Sorry, thank you. Go over a few things that we've been working on lately. Like Rick said, in the annual reports that we provided you guys, there's a lot more information about what we're doing in RAC-E. So here's who we are: Trauma Service Area E, 19 counties, 7.4 million people, 176 hospitals, over 250 EMS and first responder organizations. We have 5 air medical, 39, at least 39 designated trauma facilities and stroke. So here's some highlights from our committees. And our EMS committee, led by Kevin, I'm sure he's here somewhere, has been very busy lately in developing our regional triage and transport guidelines, not developing them, we have updating them and revising. So, and we have 3 systems in RAC-E, and that is cardiac, stroke, and trauma. And as you can imagine, it's been pretty challenging with a RAC our size. But they've done an amazing job, along with medical directors. Then cardiac committee has an initiative called Heart Safe Communities, and it's a recognition program. And basically, what it does is it recognizes efforts to strengthen the chain of survival as determined by AHA. And also our cardiac committee and our stroke committees have revised our system plans for acute coronary syndrome and stroke. So those were just voted on by the general membership in March. Our SPI committee has been developing a comprehensive dashboard, and we're going to use that dashboard basically to measure ourselves. And how we're going to measure ourselves is we're creating these accountability report cards for each of our committees, and those report cards will be will be made up of bundles of care, and those will be the items that we want to measure ourselves on, and we'll use that information and analysis to provide any professional development, training, education to anybody in our region, and it could be region wide, it could be a community, it could be an agency, whatever it is. Here, another thing we did last year, there was an extensive trial or use of this program. It's our patient tracking for mass casualty incidents response, right? So it's a virtual patient movement program. So the patients that triaged and tagged on scene, and that information is uploaded to eTracks, one of our critical applications, and it follows the patient from incident to discharge. And we've tested that one out, or used it, actually. With our regional registry, so you guys have heard Jennifer give these really amazing summaries of what she's been doing. And so our regional registry is the data collection, and that's what we'll be using with our SPI, with our dashboard. So she's talked extensively about Hospital Hub, which is a portal where EMS agencies can send their EPCRs, and then hospitals can log in different from different vendors, and hospitals can log into the hospital hub to review or to get that information. And the other thing with that is also our DSHS interface, which will upload that information from our agencies and hospitals to Maven. And if you were at the Education Committee this morning, there was a lot of discussion, and well-deserved, on our symposium that took place last month on community integrated mobile health care. I have to read that because I can't remember it. And Dr. Gandhi was our Master of Ceremony, our distinguished Master of Ceremony for it. And as you can see, we had some pretty amazing speakers. Dr. Malone, who was just here, I don't know if she's still here. Jack Ayers, one of the more renowned attorneys in emergency medicine. Chief Seals from Dallas Fire, Dr. Isaacs from Dallas Fire, and just amazing speakers, a large selection of them. And Melissa, who's sitting next to me here, was the responsible person who worked exceptionally hard on it, and it was pretty successful. It was very successful for an effort of this type for community paramedicine, especially when it's not as big, I guess. I don't know. There was just some discussion about it. So you asked for challenges and what this committee can do to help us. I'm going to let Rick go over that part.
Well, so I see we have ED and Ops Committee up there. That's an internal discussion we're talking about. We have all our functional committees, but all roads lead to intake in the ED, and I know some of the other RACs are successfully tackling challenges with a committee approach to ED Ops. So that's something that we're going to begin to talk about within the RAC. But for this committee, I think one of the things I'd like to call upon is the initiative and success we've had in recent years, particularly in trauma SPI, to not let go of those efforts. I know our RAC believes data is critical, to system performance improvement. We're making inroads in our RAC, but we'd like to see a continued emphasis on statewide efforts at SPI. And in fact, I think this morning Jennifer, mentioned that perhaps an opportunity is ahead of us in the GTAC environment for an SPI initiative statewide. Thank you.
Thank you, Rick. Any questions for Rick? RAC F.
Good afternoon. In the last quarter, we hosted our annual Emergency Management and Healthcare Conference that concluded with our annual exercise, and the focus for this year's exercise was infectious disease. We've had 2 new registrars at 2 facilities, so we're continuing our trauma registrar training, injury prevention related. Our trauma registrars have pulled data, and we're developing 5 new injury prevention programs that we're going to try to implement over the next 2 years from that registry data. 3 of our counties hosted Kids Safe Saturday during the month of April, and our biggest downfall has been the loss of 2 of our facilities due to closure. So we're continuing to work on plans to ensure the appropriate care of our patients in those counties.
Very good. May I have questions for Shay? Thank you. RAC G.
I guess probably our biggest accomplishments over the last couple of months have been the fact that we've actually had 2 actual incidents where we've had to implement our AMBUS and deploy a lot of our regional assets. So with the tornadoes, we had a facility that was hit that was actually a long-term care ventilator facility that had 70+ patients in it, and they've had to transport those ventilator patients to the facilities there in Longview, and then after that, a few days later, they actually were very instrumental in moving several of those patients to Katy to another long-term facility. as well as the incident in Van that just occurred last week. So we've been very busy with that. PI-driven initiatives, we've just recently set up a partnership with the Coalition of ATVs and are working on a PSA that they have just completed, and that was actually driven off of some of our PI data through the RAC due to the fact that we've had so many ATV incidents with underage children. So that PSA will be being released. Some of our other initiatives that we're working on, of course, include trauma as well as stroke and STEMI. We work with, have teamed with Mothers Against Drunk Driving and with Pay Attention East Texas to try to get PSAs out regarding, texting and driving and drinking and driving, as well as working with some of the Shattered Dreams programs and some of those PI and injury prevention. We've also taken out some billboards and newspaper ads for early stroke and STEMI recognition with signs and symptoms for those things. Our education, we continue with our topic and SANE annually. We also help host some of the symposiums for trauma there in our area. So we've been really busy with that. I guess probably the biggest struggle is with the implementation and the utilization of the assets. Even though those assets were funded, it takes a lot of manpower and a lot of financial backing to actually utilize those assets. So, that continues to be an ongoing struggle in that time frame between, the actual implementation and receiving any of that financial back if it gets implemented through the state side of it. So,
Thank you. Any questions? RAC H.
That'd be me. So RAC H is small RAC. We got 8 hospitals, 7 EMS providers, and 1 air medical service that resides in the region. Sometimes that can be a great thing to be so small, and sometimes it can be a very challenging thing, i.e. human resources to get things done. Just in this first wave of everybody giving a report, I see super value, because what we did just recently was team up with SFA, the university, and created an ATV safety prevention video. So I can see where sharing information may be eliminating duplication of effort. So, but it's about a 4-minute video. It's in the same thought process as Hot Rac's drowning video that they did a couple of years ago, where it's, it's about a 4 or 5 minute thing, and it talks about it. So we're real proud of that. I would love to bring that maybe to the next trauma systems and show it. It's like I say, it's 4 minutes, or to the RAC chairs at some point, just to share. And it's shareable. It's not copyrighted or anything like that. Trainings that the RAC's funded or sponsored are trauma nursing core courses. The RAC does have a couple of resources that can help hospitals with their designation preparations or redesignation preparations. So we do some of that. And then we just last month participated in a EMTF regional inter-RAC mass casualty event, and the focus there was hazmat and mass fatality management. So that was good, kind of in the after-action part of that. Quasi-trauma related, for the last 4 years we've brought in Bob Page. Some of you guys may know him. He's a phenomenal speaker, and we always get him to do an annual 12 EDKG interpretation course. That's a 1-day, all-day course. Great. And then we'll usually piggyback another course that he does, like using your stethoscope or capnography reading, things like that. So that originally started out that it was predominantly all EMS guys coming to that, but as word got out on the street, last year we had a lot of ER nurses and critical care nurses that were interested in that. So that's been a win for us. And then last but not least is, we do like everybody else I'm sure, is we do the annual needs assessment of the providers, and our RAC is it's largely made up of first responder organizations or volunteer fire departments. It's probably half the room at the RAC General Assembly meeting. And so luckily, knock on wood, for the last several years, based on those needs assessments, we usually give away about $40,000 for stuff, for the first responders to do what they do on the street. And then as far as specific needs from this committee, I don't have anything identified at this time.
Thank you. Anybody have questions for Scott? So is Irene in the room? Irene Lopez? The Trauma Registrars Work Group. The difference between the Registry Work Group and this one specifically targets the development of the trauma registrars in Texas.
We just had a good conversation with DSHS regarding their goal towards getting the registrars in the state ready for the potential activities with the TQIP piloting. So we've just kind of continued to encourage the education and alignment with the new data dictionary and trying to just help reinforce that. So we want to just kind of stay in the loop with everything that's going on with that so we can continue to kind of help support the registrars as we need going forward.
Good. Thank you. Courtney's not here, but Courtney Edwards and Wendy McNabb from Lubbock developed the electronic medical record implementation guide. That is posted on the website if you have any questions. Regional PI, Christy, you brought that up.
So in our RAC trauma meeting, it was brought up how is there a process in place already from RAC to RAC for process improvement, and kind of discussed it, and we realized some RACs are further developed than others, and so I don't know where it needs to go at this point or if it's an issue or not. It was just something that was brought to my attention and I was asked to bring it forward. Any other comments from anybody?
Everybody hear Christy's question? So all I can tell you is I know that that's a RAC criteria, is to have a systems PI committee. I don't know if Rick wants to talk a little bit about it from Trauma Service Area E, but we struggled a lot to get that started, and we started by blinding all the cases, and then we broke it into an open committee and a closed committee. Closed meaning that there were specific members. Open was things we talked about openly. Dr. Eastridge, I know y'all have a robust committee in San Antonio. Want to talk about yours?
That's basically the way we do it. Everybody, comes in. Everybody signs the, a confidentiality agreement. We have a submission process for system, basically events that meet sort of system developed thresholds. We have a secure method to submit those to the region. And then as the PI chair, I look at those with the leadership, and we sort of first vet them and see if it truly is a system issue. If it is a system issue, we bring those for presentation. So whoever submits the issue comes to the PI meeting and basically presents the case, and then we talk out the case in committee. And basically it's a closed forum with controlled access.
Okay. Christine, Wanda, when y'all want to comment?
While she's coming up, if I can make a statement or question. I think we need to have an audit filter statewide, and one such audit filter that goes between RACs is greater than 2 transfers. And the reason I think that would be statewide is the registry should be able to get a patient going through multiple institutions within a day. So I think it should be possible to pick it out, and then that can be sent to the RACs that are involved as one filter.
Okay, hold that thought for a little later.
We have similar processes where we have both open and closed committees based on the activity. One of the things that we do that might be a little bit different is, as the individual entities, whether they be EMS or hospitals, send referral information back to other facilities like length of stay or those sorts of stuff, they copy the RAC on every one of those. And so we collate that as a region, and then we can identify which are the highest indicators. So I'm sure it's not a shock to anyone that length of stay in the emergency department greater than 2 hours prior to transfer is obviously our number one. And then our group just set criteria for specific pediatric and also senior, that we have criteria there. If we have a hard time sort of identifying where the threshold is if your facility gets 5 or 10 or whatever that threshold is, then they get a referral from the RAC that their individual entity is demonstrating a trend, and would they please respond to how they are dealing with that trend. What we found is that Facility A will send a referral and they think it's only happened one time, and Center B will send a referral to the same entity and they will think it's only one time. But when you begin adding all of those up, it turns out that there may in fact be a trend that no one institution had previously identified.
Very good.
We have a little bit different approach in Hot Rack. We've actually have performance measures for our pediatric partners, which include inpatient. Our trauma covers pediatric, adult, and geriatric. We also have stroke indicators. We just started a EMS registry, so we gather information based on indicators out of our registry. We also have, and those are discussed in open forum, but de-identified whole numbers at our physician advisory meeting, which has representatives across the board. We also have it for STEMI. Then we discuss the global numbers, but we also discuss any system cases where the system protocols weren't followed. And our lead trauma center always reviews all of their deaths with the group, and we review all TPA patients.
Very good. Does that give you some answers?
Mm-hmm.
Okay. The next item on the agenda was referred by Robert Winchell, and it's trauma activation process, and he's questioning looking at it at a statewide basis. And so he's not here today. He's in Paris working on something with the Cmte, not Paris, Texas, Paris, France. So we will defer that to the next meeting. And then the next item on the agenda is the standalone ERs. That was brought up at the GTAC Council last meeting. And so that we were asked to send representatives. I know that was it Dr. Greenberg was asked to create a task force. And so the two people that we specifically wanted to be on that from our group was Dr. Winchell, Scott Christopher, and Lori from the pediatric side. And so to my knowledge, that group has not met. And then this is May. May is National Trauma Awareness Month. So of course I brought data for you. So there's a lot of data. You're going to see a lot of information. So you're going to have a lot of questions. And so this PowerPoint is being posted to the website. So today, after today, you'll probably see it on there tomorrow. So just keep that in mind. All this data came from the RAC, so if you're, from the regional state registry. So if you're looking at it saying, I don't think that's right, don't shoot me. Go to the registry, and the registry is going to say, go to your RAC, because that's the data that's being submitted by the individuals specifically from your RAC. So it's data that's coming from your RAC, from the individuals in your RAC. So if we looked at it, and this is the same data that I used to testify in the legislation. So this is one of the things that you can see the breakdown from the level 1s, 2s, 3s, and 4s. And I think it's interesting, there's 329 patients from facilities that are non-designated that are sending data in. And so this is just another way to look at it. The level 1s, the number of patients that are being submitted. So you can see again the breakdown, level 1s, 2s, 3s, and then the non-designated facilities. So this is interesting. If we talk about trauma care, we look at the driver responsibility bill. You know, we're talking about trying to get the money out, right? There's $290 million of uncompensated care that was requested. And if you look at the total amount spent, so again, I have to go back to grade school, and so this is like hundreds, thousands, millions. So you can see we're spending, there's a lot of money spent on trauma care in Texas, right? So $290 million is what's uncompensated. So you can see that hospitals are indeed trying to get that money recuperated or reimbursed, and there's still a shortfall. And so you can see the breakdown of the charges. Now this is a slide, this is a year old, so this is 2011 data. They showed this in 2012. We all said, very good, the Texas trauma system is doing really well. So this is a comparison out of the data from our registry at the state level to the National Trauma Data Bank. So if you look at the National Trauma Data Bank, which is in blue, you'll see that the mortality rate is 3.8%. If you look at the red data, which is Texas, you'll see that our mortality rate in 2011 was 2.78%. So we are saving lives, and that was the message that was sent to our legislators, that we use the funding to save lives, and that we're building infrastructure between EMS and hospitals purposely to save lives. And so if you look at the mechanisms of injury, those of you in the back can't see a lot, but the two mechanisms that fall into the highest categories are always falls and the motor vehicle crashes. So if you take them all and roll them up, you're going to see falls causes the most ED admissions and the most hospital admissions. This is looking at the fatal crashes, fatal events, and again, you're going to see falls number 1 and motor vehicle crashes number 2. And then if you look at counties, so this is the new data that we pulled out. And so again, I was trying to talk to the legislation, and I wanted them to understand the size of these racks and what they encompass. So you can see this just shows you how many counties are in each rack. Now this is interesting. If you look at falls, so the mechanism is in blue, the fatality rate is in red. So lots of falls, but motor vehicle crashes is what's killing Texas. This is by trauma service area, the number of transfers by trauma center. So this is kind of complicated, so you have to be close to see it. But the level 1s are in the blue, and red, and the level 2s are red. And I think greens, I can't even see it myself. 3. Oh, well, now turn it off.
Now you've done it.
There we go.
It's complicated, but the bottom line is each rack we broke it down into the levels and the transfers. And so again, when you get the PowerPoint, you get it off the website, you can see the breakdown. This is runs by EMS, the frequency by each rack, and then pediatric runs, and then the geriatrics. And again, Chris's team pulled this data out, so I have to say thank you to them. So it's, I'm not going to go through this particular slide. You can pull it out when you look at it. So this is the registry submissions. These are the number of submissions coming out of your rack going to the state registry. And it starts with A and goes all the way down to B, so you can kind of see your numbers. And the large one is rack E, and then rack P and rack Q. And then this is the payer source for the state of Texas. And you're going to see that auto insurance has a high pay and then self-pay. So when you talk to the legislation, $290 million of uncompensated care, you're going to see predominantly coming from this particular category. And so if you look at the number of transfers by ISS, so we broke it down, 0 to 9, 10 to 15. Those of you who do ISS, you know exactly what I'm talking about. And then you can see the total numbers. So it's broken down by racks. And when you get this, again, you can look at it and see if there's an opportunity for your rack to address issues. And then this is age. So you can see it broken down, less than 15, 15 to 64, 65 or higher, broken down by rack. Got any questions?
On the previous slide, there was a lot of unknown.
Yes.
ISS.
That's because it's not in it. So, you know, if you look at the number of hospitals they're saying they're non-designated, you'll see there's a lot of unknown and not missing. We cannot hold the rack at the state level accountable for that. So who should we hold accountable for that? The hospitals are sending that information in the EMS agency. So there's the greatest opportunity for me is to make sure the data that we send in is correct and accurate. That was one of the reasons why in November we pushed to have the National Trauma Data Bank data elements accepted as the state criteria and the same process for validation. So those of you who use the National Trauma Data Bank know that you can't send in data that's not complete, right? And then this is, in the age category, we talked about this. So Dr. Gandhi asked about people who are transferred twice. So this is out of the state registry. So if the patient was transferred twice, you're just going to see that listed. I'm just going to talk about trauma service area E because that's where I live. You can see from the trauma centers, trauma 1, there were 19 patients, 56 in level 2s and 3 in level 3s. So again, you can see the total number over there. So that's a great opportunity for us to drill down and find out why are these patients being transferred twice. And this is ISS by breakdown of these same patients who are transferred twice. So you would think that the patients who have these type of injury severity scores would be transferred, but reality is the 35. So it may be appropriate. They may be the pediatric patients, and we're trying to get them to Lori's facility or to Sally's facility over Fort Worth. But we don't know without getting more information. And this is RAC transfers times 2 by payer. So again, if you look at Trauma Service Area E, Blue Cross Blue Shield, there's 4, Medicaid 10, Medicare 4, and you can see the breakdown. So again, it's an opportunity for each RAC to drill down a little closer. And then I asked for the patients who arrived by shock, and so the data definition was anybody that comes with a blood pressure 90 or less. Again, I'm just going to pick on E. So level 1, level 2, and level 3, you can see 491 in the level 1s, 179 in the level 2s, and a total of 1,287 in that particular year from Trauma Service Area E. Then I asked the question, well, how about those that arrived in shock? How many are transferred? So again, you can see there was a total of 783 patients that were actually transferred. They were in shock from one level trauma center to another. And so again, just looking at E, there was 3 transferred from a level 1, 14 from a level 2, 21 from a level 3, and 4 from a level, 84 from a level 4, and 125 from unknown hospitals. So you see how the data, we really need that data to be accurate and complete to be able to make some decisions at the state level. And then I asked about shock outcomes. Well, what happens to them after they arrive in shock? And so you can see there are 1,100 of them died, 1,107. 1,576 of the total group went home. 11 left AMA. So can you imagine what those must have been? Nursing, to a nursing facility, 358 went to a nursing facility, 333 went to a rehab, 2 went to correctional facility, 1 went to hospice, 783 were transferred out, and then again in that missing category, you'll see there's 427. So then I asked about traumatic brain injury. So there were 25,835 that had traumatic brain injuries that were treated in the trauma centers in Texas in 2012. And so you can see the breakdown. We broke it down into the levels of trauma center and then their disposition from the hospital. So there were 1,600 people that died after traumatic brain injuries in the state of Texas. And I asked the same thing about spinal cord injuries. So there are 1,258 spinal cord injuries in the state of Texas in 2012. And deaths, there were 119 spinal cord injuries. And you can see the breakdown of home, left AMA. So 420 went home. 141 went to nursing facilities, and 373 went to rehab facilities. Then we asked about mortality rates. And so again, you can see the breakdown. And again, it's a lot of data here, so I started at first to do PowerPoints for each one of these slides, and I decided I would just put it on the website, and you can make your own PowerPoint for each of your racks. But one of the things we did do is look at, for each of these levels in 2012, and we compared the Texas mortality to the National Trauma Data Bank. So again, in this slide, Texas is blue, and the National Trauma Data Bank is red. So in the level 1 facilities, you can see overall in the National Trauma Data Bank is still about 3.8%, and you can see the breakdown. Any questions on the data? Is there any question that we need to take a stronger approach to accurate data and complete data going into the registry? So that's probably my question to each of you that represent different RACs is, I know that the state is bringing to you all the injury severity scoring classes. I know in Trauma Service Area E we had the ATS Trauma Registrar class. So the real question, I think we should just say that moving forward, we should take a very hard stand on getting good data, complete data into the registry. Chris?
Can I just put a plug in?
Sure.
Our program has just recently successfully linked our tech stack crash records to our registry data. That's both EMS data and our hospitalization records. So this is a new data source that this committee and the various committees and stakeholders can utilize for whatever research questions or initiatives they want to do to look at different causations of injuries and different type of outcomes. So this is just an FYI that this is now available.
Good, thank you. So that PowerPoint that I showed you is what the legislators got, the Senate got the other day. In addition to that, they got the list of all of the all of the hospitals who did request 3588 reimbursement of the driver responsibility bill. So they do have that information, and you can ask them about it.
Jory.
Yes.
I think last time we had quite a bit of conversation about the elements that are required and mandatory in the state registry. Have they made that decision? Because a lot of us thought in January that they were going to start collecting all 88 elements. And then we kind of had the discussion that it would reject a record if there was only 9 that wouldn't reject a record. So where are we at with that?
Chris? Sure. You better come sit up here close.
So this question was discussed in the work group actually earlier today. And our legacy data standard had that mandatory required, and which required intuitively wasn't what we would think as required. But now as we switch to the NTDB and the NEMSIS standard, we're following that as the exact logic, meaning that if data is getting pushed up to the registry, it has to follow the rules for those standards. So those standards will reject a record, like Jory mentioned earlier, then our registry will reject that record. And so our standard, DSHS standard, is now following these two, except for the changes of maybe 1 or 2 elements, such as patient name, first and last name for NTDB. That's not in there, but we require that for our linking purposes. Going to NEMSIS, patient last name and first name is in there, but that's a recommended element. So we changed that to a more restrictive element by collecting it. So we are going to the standards. So if the standards rejects it, then the state registry will reject it.
When will that start?
Good question. So for the EMS part, we're right on the cusp. I was hoping to be able to say that we're certified for this at this GTAC. We're waiting for NEMSIS to break our system. If they can't break it this time around, then they're going to give us a certification. And we're now doing a little beta testing on our XML file submissions for NTDB 2014. We had as of today, we had an issue with the withdrawal of care data element for some reason. There was an issue with the date and time, those 2 TQuip questions. Once that gets fixed, then we'll be able to do a little bit more testing on that with some identified facilities and providers and vendors, and then we'll be able to start collecting that.
So maybe start July 1. Will we go back and complete this year, or maybe start January 1 of next year, or have you guys?
So that's also another question that we're talking about. DSHS will then be collecting 2 different standards for EMS and 2 different standards for hospital, both the legacy standard and the national standard. And in order to give our providers enough time, we're looking at a shutdown of the legacy standard on December 31st of this year, so that starting January 1st of next year, we'll only be collecting the NEMSIS data or the NTDB data, not our DSHS legacy data. This will give us opportunity to have a unified data standard across the entire calendar year, as opposed to different data standards collected throughout the year.
Thank you.
Good. For our updates, Dr. Easter, do you have anything from Region 6 COT?
I'm not the chair of Region 6 COT, but not to my knowledge.
Sheila, do you have a question?
Yes, Jory, I just want to tell you thank you for the presentation of the data, and I think it is very important that we look going forward. So when you went through that data, those data points, I was very interested to see how many level 3s and 4s got shock and TBIs, and if we're going to do the TQuip data going forward, with the 3s and 4s. I think it's very important that we get something together to make sure that they understand what patients are included, that definition, because our data is going to be dirty if we don't do that.
Right.
And there were quite a few that were included in there. So
there's another part on another slide that I have that I didn't include it in this one, and the reason is because I had a lot of questions about it, and Chris and I have gone back and forth about the data that it shows. And so the ones that were transferred, I asked, well, where did we know that these patients were transferred from these level of trauma centers? Where did they go? And there's a lot of patients who are going to lower level trauma centers and to non-designated facilities. And so that raised a red flag to me. And so, of course, I wanted more information. Why? How can you send a patient that's in a trauma center, and these are level 1 and level 2, level 3, and level 4. They're not level 4s doing this. There are a lot of level 1s. So I asked the question, how can that be? You know, and so anyway, we're still working with that data, trying to figure out and get good data from that, and then hopefully we can bring that to the August committee. But that data shows you that there are a lot of patients who are very sick and very injured going to these level 3s and level 4 facilities. Okay? Good point, Sheila. Texas Trauma Coordinators Forum. Courtney's not here. Is there anybody from the forum that wants to speak up?
Yes, but I'm having a name blank right now. We presented the Lifetime Achievement Award in trauma to
Kathy Perkins?
Yes, Kathy Perkins. Her name went blank. I apologize. And then the Trauma Champion of the Year award went to Janice Markwartz from Hill Regional. And so those were two very deserving people that we celebrated at our meeting. We had quite. We decided to put on all the future agendas the Texas T-Quip project from a standpoint of what kind of educational needs are our folks going to need with regards to that, and just kind of staying on top as a board and as an entity as that project matures. Can anybody else think of anything else?
Brenda did a presentation on the top 10 deficiencies.
Yes.
I thought it was really
Awesome.
good and gave kind of points on how to prevent those deficiencies in the facilities. So I thought it was really good. We actually had 58 people that attended the TDAC course the day before. Mm-hmm. So there was a lot of new people there, and it was good information that they got.
Very good. Very good. The level 4 facilities, most of the ones that have called me, and I've told them if you have a question, call me. The level 4's questions, and you're not going to be surprised by this. I'm new to this role. How do I learn what I'm supposed to do? And so we did direct them to the course that was in the first of the month, Monday. And then the next contact I give them to is always Brenda to help with TTAF. So again, if you are new and you need help and resources, just let us know. And the other thing that people ask about is the topic courses. So we did have a topic course yesterday. We will have a topic course on Wednesday of GTAC for August. And then we're looking for an opportunity in November. So the next topic class will be June 17th in Tyler, Texas. And then August the 19th here. And so if there's anybody that wants a course somewhere else, if you'll just let us know, we will try to work with you. We have gotten the Society of Trauma Nurses. They were saying if you cannot guarantee 25 people will be there, that they would not allow us to hold a course. Well, they'll let you have a course, but you got to pay for all the 25 people. So we did get them to back off of that as long as there's somebody that sponsors the hotel and the food or the room and the food. So we've moved topic around a lot in the last couple of months. We had one in Arlington. So if anybody has any questions about how to schedule it, if you'll just let me know, I'll be happy to work with you on that. Colin, did you want to say anything about the August course?
No, that's still in the works, so, yeah.
The state may sponsor that. That's the reason I was asking.
May, yeah.
The level 3, Ms. Price?
I don't have anything specifically to report. A lot of the questions I get from level 3 facilities have to do with subspecialty coverage and responsiveness of particularly ortho or if they have neuro and that type of thing.
Okay.
If anyone has any great ideas about that, please let me know.
Lori, level 2s?
I'm continuing to participate in the level 1 and level 2 committee in TTCF. A lot of what we're talking about now continues to be the Orange Book and how people are going about addressing some of the changes, specifically with how to track the response times of your specialist, some anesthesia questions, just more or less Orange Book stuff, and did identify a couple of people that are first on the agenda for going through the Orange Book, and we look forward to them bringing back their experience and what they learned from it. So that's pretty much it for me.
Good. Dr. Gandhi, Dr. Eastridge, level 1 trauma centers, any information, any questions?
Last meeting, Dr. Winchell brought up the idea of the trauma systems again in terms of the ACS. So do we have any update in terms of, is that gone forever? Is it maybe has money now? Or
Unless we find funding to do that soon, that's off the table for the time being. Yeah.
And you said it's about $12 million?
No, it's not that much.
Do you know the price tag?
Off the top of my head, to do all 22 racks, I'd have to get back to you on a solid number. I budgeted it out. It looked like about $500,000.
$500,000
Yeah.
for all 22 racks?
Yeah, that's a tentative figure. So.
Okay.
Yeah.
I mean, I think amongst all the racks, we should be able to possibly come up with something. Unless there's a
That's a lot of bake sales. That's a lot of bake sales.
We're sitting up here in the ivory tower, Raj.
Just so you know, I know that the regional systems consultation was $60,000. So if you just think about 22 racks, $60,000, and they did give us a discount, that doesn't mean we can't look for a grant or something like that to do so. Good point. Ms. Lori, pediatric facilities?
Yeah, the only thing, we're still looking at some of the state registry reports, and the Pediatric Committee of GTAC has actually had a really good report that they provided at their committee yesterday. The child abuse stuff is one of the things we're looking at, so I'll be working with Diana from their committee as well to look at some of that data. Otherwise, I can't think of anything really specific that's coming our way about pediatrics, other than education. There's several trauma symposiums that are coming up that will have pediatric content across the state. I know there's one in the Panhandle, there's one coming up in Waco, in Amarillo, so there is some pediatric education coming up out there, but if you have a need, please let me know, and I'll help try to facilitate that need being met.
So I'm going to skip down to Alex with EMS.
Just reporting from EMS, they spoke about a QA tool that they're going to start using during their field surveys, which it's great news. And I just thought about just what we do in trauma. It's just PI, and it's good to hear that EMS is going to start doing that. There was a lot of lengthy discussion as to how to do it, who was going to review it, and all those things. And I think at the end, pretty much the committee understood what the purpose was. Also, Jennifer Gardner gave a very good presentation about integrated systems as far as talking about run sheets presence on admission and also getting outcomes for EMS. And I mean, I think it would be a good presentation for Jennifer to give at this committee. Probably not. I don't think we have time now, but probably for the next meeting, because if that can be duplicatable and it's funding, it can be allowed by funding. I think that would be very beneficial for the patient up front on both ends, on the EMS side and on the trauma side.
Okay. To the trauma center administrators and the Texas Hospital Association. So I talked to Dinah about reaching out to the Texas Hospital Association and seeing if we can do a presentation on the new gold book. It's directly to the hospital administrators and CEOs responsible for the different trauma centers. And so I have this very detailed assessment of what you have to do with the gold book to be successful. So we're trying to see if we can meet with them and actually hold a little educational meeting with them, so stay tuned for that. And then Sally. I'm waiting for Donna to come back in too.
Thank you. Jory, when I get done with E&A, do you mind if I go ahead and talk about the...
No, it's on the next slide. Go ahead.
Okay, perfect. So you've asked me to report in the past on TNCC courses.
Yes.
And one of the things that I did before I left yesterday was to look at the courses scheduled in the state of Texas. What's the remaining days in May, there are still 17 courses that are scheduled. 8 of those are full. In June, there are 33 provider courses scheduled. 15 of those are already marked full. July, there's 22 courses scheduled, only 2 marked as full. In August, there are 20 courses scheduled, 1 is marked full, and already in September, there are 14 scheduled. So there'll be more September courses scheduled as we get closer to September, I'm sure. As I mentioned in the TTAF meeting yesterday, the Emergency Nurses Association Day on the Hill was April 29th. There were over 100 emergency department and emergency nurses on the Hill. One of the things that we were advocating for was trauma center grants and trauma center funding. We got very good response from the legislators that we visited with. I personally visited with Congressman Gene Green from Houston, who is a big supporter of trauma center funding, and you know, he talked a lot about the 2 level 1 trauma centers in the city of Houston, and I had to remind him that there was a 3rd level 1 trauma center in the city of Houston, and that was Texas Children's. So I think there are a lot of people, Dinah talked yesterday about the state level not recognizing that level 1 children's hospitals are level 1 trauma centers, and so that's not just the case on the state level, but at the federal level as well. So we had a good turnout and some good responses. We also talked a lot about mental health reform, a little focused HIPAA reform, and how families should be able to get information about their mentally ill family members, and Medicaid reforms so that there would be more inpatient psychiatric beds, and to try to take the heat off emergency departments that are holding psychiatric patients in the ED for sometimes weeks and months.
I'll just give y'all a little perspective. You know, Parkland has a dedicated psych ER, right? And it is a 17-bed unit. It is not uncommon to have 17 patients in that area and 30 APALs in the emergency department. So when people start talking about this, so if you don't know what an APAL patient is, it's somebody that has gone through this apprehension, protective order by the police. So when they bring them to your hospital, you are obligated to have at least a one-on-one on that patient. So it really can tie up your emergency department very quickly, trust me.
One of the nurses that I did some visits with was Kim Grant, who is a manager in that psych ER, and she can tell some pretty compelling stories, and did tell some compelling stories. And she visited with Congresswoman Eddie Bernice Johnson, who's we anticipate will introduce this mental health reform bill coming up real soon. So it was a good impact. And Eddie Bernice Johnson is a old psych nurse, so she has a passion for that. So you ready for me to talk about those transfers? Inadvertently, this particular agenda item did not make it on your agenda, but if you would please go to the meeting notices and documents on the GTAC website and find the document titled Considerations for Transfer and Consultation of Pediatric Patients. That is I'm going to call it a guideline. It's not really a guideline. It is really just a consideration recommendation document that the Pediatric Committee is asking the relevant other GTAC subcommittees to review and endorse. It has been vetted through other committees. EMS looked at it today. Air Medical looked at it yesterday. Medical Directors has been asked to review it. And we would ask that you guys review it and give us your feedback directly to me if you don't mind. And then we will bring back in August, hopefully, a final draft to all of the subcommittees. So, Jory, put that on your agenda for August, please. And ask you to endorse it so that we can take it to the big GTAC committee. This is a set of recommendations for what patients should be transferred, and there's criteria for physiologic criteria, anatomic criteria, and then some other criteria. There is ABA transfer criteria for burns. There is a set of, now we have that criteria for medical patients and trauma patients. And then there is the discussion about transports teams and what those should look like. The definition of specialized transport teams was lifted directly from the Health and Safety Code, so that's already in rule. And then we have provided a list at the end of the transfer document with all of the freestanding children's hospitals, all of the children's hospitals within a hospital, and those are broke down by RAC. So we hope that this, for lack of a better word, guideline, will give you all the information you need about who needs to be transferred, where they need to go in terms of a higher level of care, and then the resources in terms of how many hospitals are available to take those patients. It was never anyone's intent to disrupt the already established transfer patterns that hospitals have, but just to give you a go-to document for who should be transferred to a higher level of care, what children should be transferred. Any questions about that? If you would, please look at that document, get your feedback to me, and be ready to vote on that in August.
Right. So everybody's going to look at it, right? Okay. Yep. So under open discussion, the other thing to talk about is TQIP. So there's two issues with that. Dr. Matt Davis has been working very diligently with the TQIP staff to solidify this Texas TQIP. And so the way that looks so far is that the 17 trauma centers that are currently participating, that are level 1 and level 2 in TQIP, will continue that participation. And the reports will come back to look like one trauma center, and they're going to compare it to the other states that are already participating as a state. So where it's at right now, it's in the contract language at the American College of Surgeons. So what has to happen is that TTAF is the one that said that they will help sponsor this. And so TTAF has to identify an administrative person to oversee the TQIP piece of that. So Dr. Davis is identified as the lead surgeon, but they want an administrative type person. So that has been sent to Dinah and to Brenda for their clarification, and they have to define an individual. The other issue that's out there is that TQIP wants to open up a trial opportunity for the level 3 facilities. And so I talked to Jane and got a list of all the level 3 trauma facilities and sent them a list that they can, or an opportunity that they can join for free. They want to bring the level 3s in to look at, you know, whether or not they would find it interesting, want to do it, if they would be too much for them. I don't think it's too much for them. I think they can do it fairly easy. They just need to know what the rules are, just like when the level 1s and the level 2s started it. So I sent that out originally. I know that there are 15 trauma centers in Texas that are level 3 that have already responded back to them that they wanted to be part of that. So this message is just for anybody else who wants to do it. It's an open issue. If there's anybody that wants to do it, you can contact Melanie. If you see me on break, I'll be happy to give you the contact so you can get a hold of them. Are there any questions on that regarding TQIP? Any questions from the members? Sorry. Any other open discussion issues? Yes. Yep, I'm going to take you right back to that. Irene? Before we do the announcements, we're going to go back to Brian and do the trauma systems plan.
Which computer is up there?
That one.
The one that Colin's at? Or
No, the other one. Yes.
The ask is just that the state continue to help us to get the freestanding EDs an entity number for the registry, so that as we continue to find issues with those facilities that are sending patients to us, so that we can track and identify them appropriately in the registries. And I know the holdup is regulatory, so we would just like them to continue to move forward to try to help us with that.
That's what the task force for the standalone ERs is about. That's one of the elements. So Again, so last time we took it from this committee and we talked about it, but several other people brought it up, and so there is a task force being assigned off the council to specifically deal with the standalone ER. Okay.
Brian? I have an update from Kelly Stowell on the mid-level group or the advanced practice. Do you want me to give that, or?
Yeah, that's fine. I didn't include it because of the conversation, but go ahead.
Well, go ahead.
No, go ahead.
Okay, she sent an email, just wanted to kind of give an update that the group has not really met since last summer, various reasons, mainly provider schedules. She is going to be scheduling another meeting for this summer, and anybody that's interested, she wants you to email her at kstowell, STOWELL, @sw.org. The focus of the group is primarily nurse practitioner, physician assistants that are involved in trauma and emergency surgery groups. The next meeting, they plan to talk about the advanced practice professional info that's in the ACS Orange Book. And then she wanted to give an update that within the Baylor Scott and White system, we're beginning to develop curriculum for a trauma and emergency surgery postgraduate fellowship that's similar to some programs at like St. Luke's in Pennsylvania, Vanderbilt, and Shock Trauma, and that she welcomes any input from the Trauma Systems Committee or other GTAC participants, and if there are any specific concerns or topics that this group needs to consider, just let her know that.
Very good.
Just one thing, Lori, she is going to do that by conference call, the meetings? Okay, because most people can't travel.
Yes.
Okay, all right.
Thank you, Lori. Brian?
All right, so in the interest of time, we'll actually go over this briefly. We're going to discuss this at the council meeting probably in great depth tomorrow because it's basically our second public comment. But we were charged with developing the strategic plan for trauma, EMS, and emergency health care in Texas. And we actually specifically added emergency health care to our strategic plan. So this is just a basic overview of what we're going to be presenting at the council tomorrow. So you can see in the table of contents, what we're going to do is we're going to change it quite a bit from the format that we had before. We're going to, rather than the vignette, which several of the developers thought that was probably too specific and probably levied a lot of room that we didn't want to use. We're just going to go to basically developing the burden of disease in Texas for both cardiac, stroke, and trauma, both with some bullet points and in a graphical format. And we'll work with Colin. Colin's done a lot of work with that already to actually put the graphics in this document. And then we're going to set the document up a little bit different than the table of contents listed here. We're actually going to set it up really by the structure of the optimal, optimal trauma system development guidelines that were put out by NHTSA. So it's going to be basically pre-hospital, acute care, post or convalescence and rehabilitation. And then we're also going to add a section for infrastructure and another section for support. So again, we're going to have a page each for burden of disease for any of these. This document is actually online if anybody wants to peruse it. We're actually going to make some, tweak it. Well, I've gotten some comments back from all the committee chairs, less trauma systems so far. And we're going to have some pretty good tweaks tonight. So if anybody reads that document and wants to give me any input, please feel free to forward that input along. Start off again after we do the burden of disease, just the vision and mission of the Texas Emergency Healthcare System. And then there was a lot of verbiage in the old document that went through the law line by line that is actually a fairly boring read, and it really doesn't do anything for the reader. So we really condensed that down to a simple history of the trauma system in Texas and the strategic plan and the value of the strategic plan. And I opened up the wrong document. All right, let me go back. I have a... what got lost from this document. So you can see that this document basically is set up that, again, it's going to be formatted a little bit differently, but all of the headers have a brief explanation of the header. So here in prevention, there's a brief explanation of prevention, and most of these have really been made as general as possible so that they can really be conformed to the entire emergency healthcare spectrum. Where there are nuances that really need to be included for trauma or EMS or cardiac or stroke, we have actually left those in to this little vignette. And then the objectives on what we want to attain from this strategic plan is listed next, and these objectives came from the committee chairs, and then followed by strategies. Now, this is very similar to the last document, and again, one of the problems with the last document we discussed as a working group was, again, the document didn't have any teeth to it because it basically told us a lot of things we should do, didn't really tell us how to do them, and didn't assign any responsibility for doing them. So we are actually going to align, develop this current document that after the strategy portion, there will be a tabular format that lists the strategy, lists a metric to measure the strategy, lists the responsible agency, committee, person, and basically a goal timeline. And again, that will give the committees, give the council basically some impetus to get some of these projects, these objectives and strategies initiated. So Jory asked me to just show the basic template of how we're going to do this. Again, this is online. It's broken down into these various topic areas, but we'll conclude that there, and anybody that wants to get into the sort of the minutia, we will probably do that at the end of the council meeting tomorrow. Are there any questions?
Brian, I do have a question, and that is, if you look at what TQIP has done, and they've published those guides on, the MTP, the elderly,
right,
the brain. So, are we going to integrate that into this plan?
So that's a great question, Jory, and that actually alludes to my comments earlier with the medical directors, and I'm actually in the right section here. So, clinical care is going to be broken up by pre-hospital, acute care, and convalescence and rehabilitation. In the acute care section, you'll see basically objective number 4, apply evidence-based best practice to minimize practice variation. And then the strategy, one of the strategies to that will be to define data elements, develop clinical practice guidelines. The metric will be development of clinical practice guidelines. I mean, it might even specify for resuscitation and transfusion, elderly, a couple that we can actually do. And then, the responsible committee will likely be trauma systems, particularly with the medical directors group, and then a proposed timeline. So that's actually a great example of how we intend to do this.
Good. And then the other question that I would ask is that we see this a lot is, there's a question about what should a trauma medical director's job description say, or the EMS medical directors, and where are their accountabilities? So is there an opportunity to have like appendices or something in here so you can provide some examples?
There is. Remember, this strategic plan document is for us. It helps us make our trauma system better. Originally, we had talked about, well, we want to use this for legislators, and what legislator is going to read a 30-page document? So part of this plan is to put that kind of fine detail that Jory was talking about in this, because that's to help us develop our system. And there actually is a specific bullet here in this about developing a one-page legislative white paper so that it's basically your elevator speech to legislators.
Good. Okay. Any questions for Brian? And again, that's already posted. You're going to talk about it tomorrow.
It's posted. It will be refined between today and tomorrow, but that is the 80% solution is online now. Again, if you have any suggestions, please forward those to me, and we will go over this in detail at the council meeting tomorrow.
Perfect. We have 1 minute and 40 seconds left, so are there any other open discussion items? Any announcements? Again, congratulations to Kathy Perkins, well-deserved, the Leadership Lifetime Achievement Award from the Texas Trauma Coordinators Forum. It's awesome. Nobody wants to come to the mic and talk about trauma issues? Oh, here comes my buddy.
So we don't need to have the draft when we produce the big document.
So, Joe, I just wanted to bring the attention to the Trauma Committee that DSHS is reviewing Chapter 103, the rules that govern the EMS or Trauma Registry system, and that we're now in the formal process of that entire process. And so we're just looking for a written guidance on and the rules that we provided out for stakeholders so we can then move on in the process. So I presented that to the EMS committee and also sent that to you, Jory, a few weeks ago. Also, the reports that Lori mentioned, the pediatric reports, they're available on our website. There's 2 reports. One of them is just a summary report on pediatric hospitalizations, and another one is a report looking at the differences between pediatric and non-pediatric facilities. And those are available. Also, we continue to move forward with creating the ISS capacity within our MAVEN system. And so once that's up and running, we'll be sending out a webinar to all stakeholders to let them know about the changes in the registry. And then lastly, one of my new EPIs, Casey, who's here, one of her first assignments I had to do was look at how quickly the data comes into the registry. And we noticed that by April of the following year, we get a little bit more than 90% of our projected EMS and hospitalization records. And then by mid-year of that year, we get about 99%. And so what does this mean? This means that DSHS will now be able to close out data years for analytic purposes and produce reports more timely for stakeholders to use them for their system improvement and for their work that they do.
Very good. Any questions for Chris? So our time is up, so I just want to say thank you. It is National Trauma Awareness Month. So obviously the 3 things that they're focusing on is not texting and driving, not drinking and driving, and not driving drowsy. So be safe.